week, I guess, 3 of running repairs. This week, we'll be talking about Achilles tendon pain, which very common in runners. Obviously, there's a lot of stress that occurs on both the calf muscle as well as the Achilles tendon, which is the attachment. So we'll be talking about all of that in this. If you've been to some of the other ones, thanks for coming back. If this is your first one, thanks for joining. So each week we basically just have a theme or a topic that we go over. First week was just a general Q&A. Second week was proximal hamstring tendon pain, and this one is going to be on Achilles tendon pain. I guess let's get started. So let's first look at the anatomy here. Obviously, this is our foot down here. This is our shin. So we have two different bones that actually make up the shin. So we have the tibia, which is the bigger bone here, and then we have the fibula, which is the bone on the outside part here. This is actually our left foot if we look at it. And so the calf muscles are on the back side here, and there's 3 different calf muscles when we look at it. So we have the gastrocnemius muscle, which is the bigger one on the back that when you flex your calf, that's the one that you see. Underneath that, we also have the soleus muscle, which is actually a little bit more important when it comes to Achilles tendon pain, which we'll talk about later. And then you have a very small muscle, which is called the plantaris. It really doesn't do a whole lot. It's very small. So in terms of like force production, it doesn't really contribute all that much. However, it can be a source of pain, especially for if we're looking at either a calf strain or something like that that isn't getting better. It might not be the gastroc or the soleus muscle. It actually might be a plantaris issue. And so that's kind of just our general anatomy when we look at the calf muscles on the back there. Well, we're mostly just going to be talking about the soleus and the gastroc muscle for this, but those muscles, they actually come down here and they insert to form the Achilles tendon. And the Achilles tendon attaches right on the back side of this bone here, which is called the calcaneus. And you can have 2 different types of Achilles tendon pain, which I think a lot of people don't really think about. They just think about the diagnosis and say, it's Achilles tendon pain, it's all the same, but it's actually a little bit different, or there's at least a couple of different spots here. So if you're to reach down and grab your Achilles tendon and you pinch on it, typically you're going to pinch on what's called the mid portion of the Achilles tendon, which if we look here, typically you can feel the backside where that bone is. And so most people will pinch right here, which is where that Achilles tendon, like the middle portion of it, which is why that's called mid portion Achilles tendon pain. Welcome everybody. Leave in the chat where you guys are all from. If you're training for something for running, let me know. But so basically mid portion, the part right here is where you would pinch, but you can also have insertional Achilles tendon pain, which if we look at that calcaneus, I don't want to hit myself with the femur, that would be not great. But if we look at that insertion, we can have pain right here, which is where that Achilles tendon actually attaches onto the bottom portion here. And knowing which type of Achilles tendon pain is quite important. From India, welcome. Because if you're dealing with insertional Achilles tendon pain, you actually don't really want to stretch it. And the reason why is that if we look here, and if we kind of do that calf stretch where we go this way, what you're going to be doing is you're going to be increasing the compressive loads on that tendon, which is going to be irritating for insertional Achilles tendon pain. And so that also not only has to do with stretching, but when we're looking at doing the calf raises, you don't want to go fully into dorsiflexion, which if we're looking at the calf raise, that would be toes down, heel up. And then as you go down, this is called dorsiflexion. And so when you're in that same position, it's a stretch on that Achilles tendon, which is going to compress on that insertional point. And so with insertional Achilles tendon pain, you don't want to add those compressive loads initially. So when you're doing your calf raises, you do them on flat ground, or you actually do them on a slant board. And so the slant board would be going this way. So you're limiting how much dorsiflexion you're loading into, decreasing the stretch and that compressive load on the tendon. Let me see, looking through here at some of the comments. Oh no, Oh, I'm so sorry to hear that. ACL tears, no fun. Hopefully MRI and it's just a strain, but sorry to hear that. Wishing you the best in recovery. Um, is it normal for bones to pop when doing squats? Uh, Typically, yes. What ends up happening, that pop, it's also called a cavitation. Um, um, Basically, like, you have a joint capsule. So this is the knee here. Um, and what happens is there's air in that joint. And so typically, if you're moving, so let's say you're sitting for a long period of time and then you stand up and you feel that pop, it's just gas being released from the joint. Same thing can happen with the ankle as well. Pretty normal. Obviously, if there's some pain or something like that associated with it, it can be a little bit different. So, but usually, if it just pops once, that's all right there. Um, but let's get back into uh, it really is. It's a very good hair product, keeping this hair up. But let's get back into the Achilles tendon. So mid portion, much more common. Yeah, sorry. Just reading through the comments there again. Mid portion Achilles tendon pain is the much more common of both of those. And so with those, you're looking at a rehab approach that's going to be focusing on heel raises. And it looks like someone just commented about doing slow tempo Achilles tendon pain. And um, cool, guys. But basically, when we're looking at what myotome? Do, 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 do. Sorry, but looking through the comments again. Yeah, so the rehab approach is heel raises. And essentially, what you're looking at doing is very slow. And the reason why is because tendons are slow to adapt to load. And so if you do them too quickly, they actually won't sense the load. Um, uh, thanks, guys. But sorry, let me refocus here. When you're doing calf raises, you want to perform them slowly because if you do them too quickly, give me 1 second here. Do, 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 do. When you're doing calf raises, you want to perform them slowly. And the reason why is because tendons are slow to adapt to load. One of the big issues when you're doing rehab is you perform them too quickly, and then the tendon doesn't sense the load. And then typically that's when you see comments of, I was doing calf raises and it wasn't helpful. So you want to perform them slowly. And that typically means over each contraction, it's over 3 to 4 seconds. So for a concentric contraction, which is where the calf muscles contract to lift up the heel, that's going to be over 3 to 4 seconds, and then 3 to 4 seconds back down, which is the heel lower. Uh, da, 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 Give me 1 second here. Cool. Sorry about that, guys. Um, but when you're performing, cool. When you're performing the calf raises, you want to perform them slowly. Obviously, when we talk about rehab for Achilles tendon pain, the focus is typically on that eccentric contraction, which is where the muscle contracts and it's lengthening. So for calf, I guess calf raises, basically what ends up happening is that the eccentric contraction is actually the lowering portion, and the emphasis on that was because it would help to really stretch out the tendon, which would cause the adaptation for it. But when we look at the research, we don't actually need to isolate just that eccentric contraction, which is the lowering portion. We can perform both the concentric and the eccentric component, which just makes the rehab a lot more simple because you don't have to worry about going 2 legs up, 1 leg with the lower. Just perform the calf raise slowly up over 3 to 4 seconds and then back down over 3 to 4 seconds. And so that's probably one of the biggest errors when we look at rehab for Achilles tendon pain is that the contractions are just performed way too quickly. If we're looking at the actual program overall, you typically want to perform them over 12 weeks. A lot of times people perform them just way too quickly. They might do it just based on pain. And so once the Achilles tendon reduces in pain, tomato, what's happening? Um, once the pain of Achilles tendon, once the pain of the Achilles tendon reduces, then they stop doing the rehab exercises. But the problem is that if that's 4 weeks in, you might not get the adaptation of the tendon, which just means that when you start running again, all of a sudden the pain starts to come back, and it's because you didn't actually build too much capacity or tolerance of the tendon. So most rehab programs should be at least 12 weeks. So it's going to be a lot of calf raises, but that's just the way tendons are. They're much slower to respond than muscle. So perform them slowly over 6 to 8 seconds. So it's a 3 to 4 second contraction up, 3 to 4 second contraction back down with the heel raise, and then performing them over 12 weeks is the standard for rehab. When it comes to the actual reps and sets for something like that, that's when we want to look at somewhere between 3 sets of 10, 3 sets of 15, somewhere in that range. And that's, sorry, going to look through the comments here, um, which is pretty typical for most rehab programs. 3 sets of 10 seems to be the standard, but some of the research that we've seen have gone up to 3 sets of 15. So just want to make sure that you're performing a lot of calf raises, although there does seem to be a trend that we're reducing the actual volume of our rehab program. So instead of doing 3 sets of 10, 3 sets of 15 with body weight, for example, that will increase the intensity of each calf raise. So we'll actually load it a lot heavier. When we're looking at some of the research on adaptation for tendons, it's somewhere between like 70 to 90% of our repetition max, which means that body weight not going to be enough to actually get the tendon to adapt to the load. And so, loading heavier with either like a backpack with some weights in it, or using a barbell or a dumbbell or something like that, just to increase the load. Obviously, a calf strengthening machine works well as well. We learned about myotomes, for example, the Achilles tendon. Yep, 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 yep. Hello, tomato. Welcome. But yeah, so I guess to summarize all of that from a rehab perspective, muscle contractions over 6 to 8 seconds, performing them slowly. That way the tendon can sense the load. Uh, not necessarily more reps with less weight. The trend actually seems to be doing less reps, more weight, if tolerated. Um, I think a lot of the time when we look at rehab programs for Achilles tendon pain, that it's 3 sets of 10, 3 sets of 15, uh, body weight heel raises for a very long period of time, and then the tendon just doesn't adapt to the loads. And so people, like I said earlier, they kind of say like, I tried doing heel raises, I've been doing rehab, and it just doesn't seem to be helping. And part of it is not necessarily maybe just the actual exercise, it's actually the intensity of the exercise. So the trend for tendon adaptation is to do less reps, heavier weight, if tolerated. Obviously, some calf raises is probably better than no calf raises, depending on what the tolerance is. But the trend seems to be for rehab, less reps, more weight. What are the signs that physio isn't working and you need to see a doctor? Um, that's a good question. Obviously, like whenever we're looking at rehab, we want to make sure that the diagnosis is right. And so Achilles tendon pain is pretty straightforward when we look at the criteria. One, it's pain with loading. So if you're getting pain with running, if you're getting pain with the calf raise and all that kind of stuff, then loading. If loading the Achilles tendon is painful, then you could be fairly certain that's kind of the criteria there. Um, but once the criteria is set, then you could be fairly certain, especially with pinpoint pain right on the Achilles tendon. Um, but, if after 12, 12 weeks, 24 weeks, or something like that, the pain just seems to persist or is getting worse, that would be a sign to go get a second opinion and kind of see, maybe there's a tear of something, maybe it's a referred pain, stuff like that. And so, I think the nice thing about Achilles tendon pain is that the diagnosis is straightforward. It just takes time. That's the crappy thing about tendon issues is that they're just really slow to respond. So 4 weeks, 8 weeks, that's just not enough time for the tendon to adapt, get stronger, be able to tolerate better load. Um, Obviously, if there's a change in symptoms and it's not pain necessarily, especially with loading, it's numbness, tingling, can't bear weight, that kind of stuff, then obviously that would be a time to get a second opinion as well, because either the original diagnosis has changed, or there's something else going on. And so those are kind of the things to look at. Although, uh, always getting a second opinion can be helpful just to kind of make sure that you're in the right track, because you don't want to spend 12 weeks doing something and just not getting any sort of results. Um, but yeah, that's kind of what you're looking at there. The interesting thing, we talked about this in the beginning, or we alluded to it in the beginning, is looking at the different calf muscles. So gastrocnemius and the soleus muscle are the two main calf muscles. And when we look at Achilles tendon pain, it actually seems that the soleus might actually be the more important muscle. And that one's the deeper muscle of the calf muscles. And when we look at strengthening in general of the calf muscles, it's interesting because the EMG studies, which is the electrical activation of the muscles, if we look at a straight knee versus a bent knee variation of a calf raise, there doesn't seem to be much difference in the activation of the muscles, which makes sense because both the muscles help to plantar flex, which is just pointing the toes down, and so it makes sense that both the gastrocnemius and the soleus muscle would be active when you're doing that. The interesting thing, though, is that when we're looking at Achilles tendon pain, is that a bent knee variation might actually load a deeper portion of the Achilles tendon, which is where the injury typically occurs. And so, from a strength perspective of doing calf raises, it probably doesn't matter between doing a bent knee versus a straight knee variation. But when we actually look at where the tendon is being loaded to get the deeper tendon to get loaded, then actually doing a bent knee variation might be better. Um, let's see. What if you get pain after sitting? Tendon pain or something different? So typically with tendons, there's a warming up period, and so initially, it can be painful for like the first couple of calf raises, or if you're going for a run or something like that, then there can be some pain initially, maybe like the first 5 or 10 minutes into a run, and then once the tendon warms up, there's less pain. If you're getting pain afterwards, one, it could definitely mean that something else is going on. But what it can also mean is that you loaded too much. So when we look at the criteria for loading a tendon, one, we're looking at response 24 hours after loading. If there's an increase in pain, a baseline pain, potentially means that there's too much load. And so that's where we might decrease the intensity. So decrease the weights that we're using with the calf raises, or decrease the volume. So decreasing from 3 sets of 15 to maybe 2 sets of 15 or 3 sets of 10, whatever is a reduction there. The second one is no pain during sleep, which with Achilles tendon pain typically isn't as much of an issue. However, if there's an increase in pain on the Achilles tendon, then during sleep, then potentially you loaded too much. Um, and so those are typically the loading principles that we look at with tendon pain in general, but we can also expand those criteria to different issues as well. So even if it's like patellofemoral pain, which is just commonly known as runner's knee, or something like that, we can still use that same criteria. It doesn't have to be tendon specific. Is tendon pain due to a load issue? Yes. Um, so when we look at tendon pain, and you probably noticed that I use the term tendon pain versus like tendonitis, tendinosis, or tendinopathy. And the reason why is because the mechanism of or I guess like the pathology has changed. So tendonitis is what we used to refer to as all tendon pain. So you'd hear Achilles tendonitis, rotator cuff tendonitis, whatever it is. And tendonitis just means that there's inflammation in the tendon. And so that's where a lot of these anti-inflammatory treatments like corticosteroid injections and stuff like that came from, because if there was inflammation in the tendon, then you would want an anti-inflammatory treatment. The problem is that we see that that's not necessarily the mechanism. There's maybe a little bit of inflammation or inflammatory markers that are present, but it's not driven by inflammation per se. That led to the terminology of tendinosis, which just means degeneration of the tendon. And so when they looked at some of the tendons, they'd find an absence of those inflammatory markers, but they'd see structural changes to the tendon, which is why they referred to it as tendinosis, which was kind of like, I think that probably was around the 90s is when they used that terminology. But it turns out not everybody, I overheard you say. No, yeah, yeah. Let me finish the tendon pain, and I'll go back to the low reps, high weight. Um, and so basically, tendinosis was just degeneration of the tendon, and so people started using that terminology, which is where PRP injections um, became a little bit more common, I guess, because you were trying to regenerate the tendon with that injection. But now the terminology we use is called tendinopathy, which just means that there's an injury of the tendon. It's not a fancy term necessarily, but it's basically an umbrella term. And so there's two different categories that we typically put tendon pain in. There's an acute or reactive tendinopathy, which is if you ran a 5K, ran a 10K, or something like that, and then all of a sudden you're experiencing Achilles tendon pain. Typically, that's more of a reactive tendinopathy because you spiked the load with a run. So you were just not prepared to run the 5 or 10K or marathon or whatever. The tendon got irritated. And so that would be a reactive tendinopathy. And then there's a degenerative tendinopathy, which isn't a great name necessarily. I would prefer maybe like a persistent or chronic tendinopathy. And that's just those cases where you've been running for long periods of time, you've been overloading the tendon, and then you get like that pain every time that you run or something like that. That would be more of a degenerative tendinopathy. Um, and so basically, to answer your question, tendon pain is more of a loading issue. There's some sort of overload, whether it's an acute overload that you signed up for a 10K this weekend and you had it trained for it, and then afterwards you experience some tendon pain. That's an acute tendinopathy. Versus you're a marathon runner and you've been doing it for long periods of time, and the Achilles tendon has just always been irritated for a couple months, years, whatever it is, and that's just a longer term overload. And so loading is typically the issue with tendon pain in general. Um, Back to hopefully that answered that. It's obviously talking about the pathology is kind of complex. You can make it as simple as just saying it's an overload issue, but there's definitely more context that needs to occur with that to really kind of have like an understanding of it. But going back to low reps versus high weight, which is the rehab um, approach. So essentially, when we look at rehab, the emphasis was first on the type of contraction, which eccentric loading was the preferred contraction, which is where the muscle is lengthening um, as it's contracting. So for my biceps here, if I were to load the weight and then it slowly extends, the bicep is actually lengthening as I'm extending my elbow. And so that's an eccentric contraction. For the Achilles, it's where you're up on your tippy toes and then slowly lowering the heel down towards the ground. Um, and so what you're looking at, muscle contraction. But we've seen that eccentric loading is helpful, but it's not necessary to isolate that muscle contraction. And so what actually seems more important is the intensity of the load. Typically, somewhere between 70 and 90% of max is needed to get the tendon structure to change. And so you can imagine 70% uh, max effort for a calf raise is loaded. It's not a body weight calf raise, which is what a lot of people end up doing. And so they're probably underloading. And so the emphasis on our rehab is typically using a higher load, either with a backpack, a barbell, a kettlebell, something to add some more load to the calf raise, performing them slowly, like we talked about before. So each contraction being over 3 to 4 seconds. So the entire movement is over 6 to 8 seconds because you have the raise, which is over 3 to 4 seconds, and then the lower toes, heel for the calf raise. But then as part of that, if you're using a higher weight, then you're probably going to reduce the amount of reps that you're going to do because if you're doing 70% of your max, you probably aren't going to be able to do 3 sets of 15 necessarily. That's probably going to be a little bit too much. And so that's why our emphasis has gone or shifted from higher reps, lower load, which was typically body weight for a lot of people. And we've kind of flipped that when looking at how the tendon responds to loading to using higher weights but less reps. Obviously, it always depends on the actual tolerance to load. So you might not be able to get up to 70%, which is fine. But you just want to try to load as heavy as you can. Can strengthening the glutes and core decrease the load on the Achilles? Uh, not not really. It can be helpful. So we know that whenever there's pain, there's going to be a change in movement. And so let's say you're experiencing Achilles tendon pain, you might be loading more on the heel, right? So if you're a forefoot strike, it's going to load the toes more, which is going to put more load on the Achilles. I have a model. I don't know why I'm using my hand. I always end up doing that. It doesn't make sense. Here we go. So if you're running, for example, if you're having Achilles tendon pain back here, you might switch to from a forefoot strike, which is going to load these muscles back through here, to more of a heel strike. And that'll take some of the load off of the Achilles tendon. The issue is that you're going to load the knee and the hip more when you do that. And so that's where it's not necessarily strengthening the core or the glutes that's helpful. It's changing your foot strike when running. That will decrease the load on the Achilles tendon. But as part of a rehab program, you want to make sure that you're strengthening everything for the lower extremity because, one, like we were just saying, pain changes movement. And so you want to make sure that the glutes, the core, the hamstrings, uh, the quads, everything is strong enough to tolerate whatever you're going to go back to, specifically running, I guess, for this context. But it could be going back to, I don't know, going back to weight training or whatever it is. And so strengthening the glutes and core, not really going to change the load on the Achilles tendon per se. That would have to do more with your running mechanics, but still helpful in the rehab context. When I do calf raises, I get popping in my ankle. Yeah, so when you get popping in the ankle, it could be from many different things, and it's not necessarily the Achilles tendon per se. Um, so interestingly, when we look at, and it wouldn't be a loud pop necessarily, but there's a piece of tissue that actually surrounds the Achilles tendon. And when you move, sometimes there can be friction in between the Achilles tendon and that tissue. And that can create some like crackling sounds. Typically, you wouldn't be able to really hear it because it's pretty quiet. But if you were to put a stethoscope on it, you can actually hear it. And that's actually how you would diagnose something like that. I think that's different than what you're probably talking about. But when we look at popping in general on the ankle, it could be from multiple different things. Uh, Typically, you're looking at something popping over something, which obviously sounds like a well, duh type of statement, but it can be a tendon popping over part of the bone. And so, if we look at that anatomy again here, for example, The fibularis, which is also called the peroneal muscles, they are on the outside part here and they wrap down and around. Um, that can pop over part of this bone, or if there's something just not super smooth about the bone, it can kind of rub or pop over it. It can also be a ligament or something like that um, that you're feeling the popping with. So it's hard to say because it depends on like where on the ankle and is it one pop, which is typically just air in the joint, like we were talking about earlier on in this video when we were talking about squats. And if you do a squat and you feel like your knee pop once, that's typically just air pressure that's being released in the area. Versus if it's happening repetitively, then it's probably either a ligament or a tendon popping over part of the bone of some sort. Uh, let's see here. Does strengthening the calves decrease the Achilles tendon pain? Sort of. It helps to build up tolerance for whatever it is. And so, longer term, the answer would be yes. Calf or like heel raises or calf strengthening exercises are helpful in decreasing the Achilles tendon pain because it builds up its tolerance to load. Um, but and this is where it's a little bit variable. We see that exercise does help to decrease pain in the short term, but the response is variable. Some people with Achilles tendon pain or patellar tendon pain, whatever, um, they will feel a reduction in pain, but it's variable. Some people feel a lot, some people feel not very much. And so exercise in the short term could be helpful for decreasing pain. Longer term, that's typically what we're aiming for with these. Um, hopefully that answered that question there. Thanks. Was wondering since where broke my ankle. Uh, oh, yeah. In one of the previous lives on, did I do? I think I actually did one on patellofemoral pain too. Huh. Anyways, um, or maybe I talked about it in the original Q&A. But so if we're looking at an injury, let's say, sometimes you can't load it directly, right? If an Achilles tendon pain is just too intense, you might not be able to tolerate calf raises, which means that can you still do something along the kinetic chain that'll be helpful? Maybe you can tolerate some knee extensions or hamstring curls or some sort of glute exercise, then at least you're still getting some exercise. And to the previous question, exercise in general typically has some sort of pain relieving effect. And so if you broke your ankle and obviously maybe there's a boot on it or it just needs to heal, you can load other things to help. And the interesting thing is there's some crossover effect as well of saying if you have a right-sided injury, you can actually load the left side and there will be some improvement of strength on the injured side as well, even though you aren't actually loading it. And that typically has to do with some of just like the hormones involved with strengthening, that they're not just local, they're released everywhere. Yeah, obviously you can't do, if you have a Johnny Bravo strengthening program, if you guys ever watched Johnny Bravo, um, Johnny Bravo character, super buff, like for chest, arms, all that kind of stuff, really skinny legs. Uh, obviously, like if you're just loading the chest by doing a bunch of bench press, you're probably not going to have that big of calf muscles. And so there might be, when we look at loading a different area, it can help with an area nearby, but as you get further away, the response is probably less so. Um, the other thing that's become pretty popular is BFR training, which is blood flow restriction therapy, is what that stands for. And essentially, you're trying to increase that stimulus in terms of the chemical response to load. And so, the nice thing about BFR training is that you can load less but get a larger response because you're decreasing the blood flow to the area. So, essentially, with the Achilles tendon, what you could do is you would put a cuff on the lower extremity and you would decrease the blood flow temporarily. and then do some calf raises, which is going to make the stress on the tissues higher. It'll create a chemical response, and then you can remove the cuff, and then you have a higher um, response to less of a load. There seems to be um, some difference when looking at the neurologic response, though, of being that yes, you have a higher chemical response to less of a load, but your body might not be able to contract quite as much as if you were just loading to whatever your tolerance is. So while it's helpful in some regard, it might not be the best overall or a complete substitute for normal rehab. Um, hopefully that made sense. Typically on this channel, I haven't really posted too much about BFR training, but it's definitely an interesting area to focus on for rehab, because obviously with rehab your tolerance to load has reduced, and so if you can still get some sort of adaptation by using less load on the system, that can be helpful. But from what we've seen, it might not be a complete replacement. Uh, Strengthening the calves kind of does. We see that the response is variable, though, in the short term. And so, when looking at this, all this research was mostly on the patellar tendon at the knee, but there was also, I think, one study. There might have been more for the Achilles tendon. And essentially, looking at some sort of muscle contraction, there does seem to be a pain relieving effect in the short term, although the response is variable. So some people see more pain relief than others. And also, when we look at the actual loading programs for Achilles tendon pain, or just, I guess, any tendon pain, pain during the exercise is actually tolerated. And so, in the short term, there might not be as much pain relief necessarily, but longer term, uh, strengthening exercises helps to build up the tolerance, um, which then helps to decrease the pain longer term. So I guess the answer is like short term, maybe depends. Long term, yes, because you're helping to improve the tolerance overall. Yeah, pain pain is pain is an interesting thing. If you guys were here for the previous talk that I gave, no, I appreciate the sub. Thank you so much. Hopefully everything was helpful. And there's like on my channel, I have a bunch of more in-depth videos on some of these things, which can help at least provide more context and all that kind of stuff. Um, but pain is always a little bit interesting because, especially when it comes to tendons, the fear is that like there's a structural issue with the tendon. You have a tear. Um, yeah, go ahead and ask your question. Um, that pain is an indication of tendon damage, right? That's the concern. But pain doesn't necessarily mean that there's that there's some sort of like structural issue. It's kind of just alerting you to the area, but it doesn't tell you exactly what's going on. And so that's the interesting thing when we look at tendon rehab, is that pain during the exercises in all the rehab programs is okay. Typically, it's less than a 5 out of 10 is what the recommendation is, because obviously we don't want people to load and it's extremely painful. Um, but some pain, because you're loading an irritated area, is tolerated because you're trying to get it to adapt. Um, oh, awesome, awesome. Yeah, I've been trying to do more lives here uh, to answer questions and all that kind of stuff, because on all the videos there's usually comments and stuff like that, and a lot of similar comments as well. And so I think these lives really help to provide context to those questions. So building the muscles around a tissue deloads it. For example, knee pain strengthening. Uh, kind of. Um, so if we're looking at tendons in specific, let's say, If there's some sort of like structural issue with the tendon, this is called the hole within a hole, or the donut theory. Essentially, like if you have an area of the tendon that isn't tolerating load very much, because there's structural changes, typically those structural changes won't change, but you can build up strength around it, which is where the donut is, to help build up the capacity overall. When looking at like loading different areas, so let's say you have like you said, for example, yeah. So let's look at the knee, for example. If you're strengthening the foot, can you help to deload the knee a little bit? Kind of like, if you're able to have what's the word for it? Absorb more load from the calf muscles, there's going to be less load that's going to be transferred up to the knee, so it would help to deload the knee a little bit. How much? I think looking at some of like the gait, or like the running biomechanics would probably be a more helpful thing if you're looking to deload an area versus strengthening. But strengthening can be helpful. It's just a question of probably like how much. You know, I think typically you'd have to probably look lower to help deload. I don't know if like strengthening the hip muscles would deload the knee necessarily, because with each step the load has already gone from the foot up to the knee up to the hip. Um, in terms of like absorbing what are called ground reaction forces, which is the loads when you hit the ground when running. If you're looking at force generation, for example, sure, if you're able to generate more force at the hip, well, you have to produce less at the knee to do a squat or something like that, potentially. Um, let's see here. Flat feet, insoles, then had tendinopathy in the hamstring. PT said, do these strengthening exercises, including barefoot. Yeah, I think that's one of the. I think this actually falls in line with that previous question of if you are wearing insoles or something like that, it's going to change your biomechanics. So you might end up loading different things, um, and so that's why like you have to be careful with some of these things, I guess is the best way to phrase it. Commonly when we look at like running, for example, there's an emphasis to run with either a midfoot or a forefoot strike, which just means that when you're running, instead of landing here, you're landing somewhere over here with each step. And the thought is that it's more efficient or it's a better way to run. But if you're typically or historically a heel strike runner, well, if you switch to a forefoot or a midfoot strike, you're probably going to load the calf muscles more, which means that if those tissues aren't ready for that load, then all of a sudden, yeah, like developing an Achilles tendon issue or a calf strain would make sense because you're loading a tissue that's not used to it. And so you can kind of make that argument kind of further up the connect chain as well of if you change your running biomechanics, are you going to load maybe the hamstrings more or the quads more or something like that, which can lead to an overload of a different area? Sure. Um, Typically, when looking at doing heel raises, I typically like doing barefoot stuff. Shoes provide some support, specifically for like the intrinsic muscles of the foot, which are just the smaller stabilizing muscles there. And so, if you're doing barefoot, you're getting those muscles to get stronger as well. So, typically, with a lot of runners in their rehab, but also when doing something like a calf raise or something like that, barefoot, just you get more out of it, but not necessary per se. Um, what are your thoughts on healing peptides? I actually don't know of BPC, what that actually is. Um, I like a lot of like the supplements and peptides and that kind of stuff. I don't know if they're all that helpful. One, like just looking at a lot of the supplements in general, they don't make it past the stomach because the acid just burns them. And so they don't make that much impact on the tissues in specific. But there's some research that shows that some sort of supplements might be helpful, but overall, like I'm not too convinced from what I've seen. Then how do I wean off insoles? Yeah, so it depends. It depends why you're having the insoles in general, right? Um, my thing is there should always be a plan. So whoever recommended the insole should give you a plan on, is this a forever thing, or are we doing some foot strengthening stuff to actually build that strength that you need, which is what the insole is supposed to be doing. Um, Otherwise, people just kind of get left in this like weird, should I just be wearing them forever type of thing, which I know like uh when I had insoles, that seemed to kind of be the case, is that there was no endpoint on when to switch out the insoles. It was just like, oh, these help with your feet because for whatever reason, but are they needed forever? Because a lot of times when we look at the foot, sometimes it's just structural. It's just how these bones actually are, right? Let's switch this around here. Looking at the inside arch here, the structure of these bones will dictate kind of like, do you have a high or a low arch? It might have nothing to do with the actual strength of your muscles because that's just the way the bones are. And so no amount of strengthening will make a huge difference. It can help a little bit, but it's unlikely that you would go from a very pronated foot, which is just when you have decreased arch, to a very high arch. You know, it's probably just not going to make that big of an improvement in terms of the actual structure. For function, it might be helpful, but improving the structure, yeah. And so, yeah, like I think whenever you give somebody some sort of like orthotic or something like that, there should be a conversation of, well, are there strengthening exercises you should be doing concurrently? So that way you have the stability in your foot, stability, if you're wearing one of the, like a belt when you're running, or sorry, not when you're running, when you're squatting. Okay, like, do I have to wear this belt all the time? Or are there exercises to help build core stability where you don't have to do it? Um, and so, that's what you're looking at there. If you're constantly overloading Achilles, it depends. So you're looking at sensitivity, right? If the tendon just isn't tolerating very much, walking is painful. I don't know. I guess walking is really the only example there. Then yeah, loading it might just piss everything off, and then later in the day it just stays irritated. Then you might elect for strengthening something else to get the tendon to calm down because it's just too sensitive. Um, yeah, and so it really depends. I'm trying to think if there's a lot of cases like that. Um, because typically you can scale the exercise down in terms of its load um, to find an exercise that's tolerable, right? It might just be standing on your tippy toes, right? Which would be called an isometric contraction, where the calf muscles are contracting, but there's no movement in the actual ankle itself. And that might be a tolerated load. It might be with a banded exercise where you're just laying down and slowly pointing your toes away from you and then back up. That might be a load that you're tolerating. And so rehab can kind of like scale depending on what's tolerated. Yeah. Did plantar fasciitis cause the calf to be tight? Um, yeah, in theory, yes. So when we look at the actual fascial chain, the plantar fascia is on the bottom of the foot here, and then it wraps around through the Achilles tendon into the calf muscles. And so in theory, tightness of the calf muscles can pull on the plantar fascia and lead to pain. But a lot of times, plantar fasciitis, I would say, is more related to just overload in general And so the plantar fascia gets overloaded, the calf gets overloaded, and so that's where you feel the tightness and the pain. Um, duh, 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 duh. Yeah, yeah. I mean, I think that's orthotics and shoes can kind of fit into that same kind of category, right? People will recommend a different shoe, for example, and then it will kind of change your running pattern, which will load different things. And then all of a sudden, instead of what you were trying to treat, now all of a sudden you have several different issues as well. And so, in those kind of cases, that's where you're looking at going back and having another conversation to kind of figure out, okay, what's the plan here? Are we going to what other exercises, what other stretches should I be doing? Whatever it is, um, to kind of go and even just having the conversation of like, uh, I'm having more pain with these orthotics or something like that. You know, should I discontinue them? Is this what was expected because we're trying to offload whatever tissues, and then we're going to gradually transition out? Yeah, that's where you have a conversation, trying to figure out what the overall strategy is. Yeah, good, great questions, everyone. Great questions. Thanks everyone for being here. Um, yeah, I mean, if that's the case, sorry that was the experience. That's obviously not a great experience overall. Uh, you know, seek a second opinion. Go find someone else. It's always interesting because when you look at choosing a healthcare provider, obviously you want someone that's knowledgeable in whatever you're experiencing, but also just making sure that it's somebody you feel comfortable with, like being able to have a conversation about whatever you're experiencing. If it's I'm experiencing more pain with that exercise, or we added orthotics and it's painful now, being able to go back and trusting and feeling comfortable with that conversation is important. So it's two parts. Like you just want a personality that you're able to work with, right, as a patient, but then also somebody who's knowledgeable to give you good guidance. Is it reversible? Depends. Um, depends on like how long you've been using the orthotics and all that kind of stuff. Most of the time, yeah. Uh, I rarely see things that from an orthotic changes things permanently. We talked about shoes just a few minutes ago. The interesting thing with shoes, right, is that the common recommendation is if let's say you go to a running store and they look at your gait and they say, "Oh, you pronate, so let's put you in a pronation control shoe or something like that." It actually doesn't seem to change your running gait that much. Your tissues kind of just still go through the same range of motion. If it's a very firm shoe and you can't fully pronate, sure. But it actually doesn't seem to change all that much. And so, you can load different tissues that cause irritation, but uh, orthotics and shoes probably don't make as large of an impact. The exception being that if you're changing from uh, like a normal shoe to like maybe a minimalist shoe, if it's like the same cushion and similar style, but maybe one's more geared towards pronation versus a neutral shoe or something like that, that latter case probably isn't going to change the mechanics that much. Switching from like a maximalist shoe, like a Hoka or something like that, to a minimalist shoe, like a Zero, you're probably going to have some biomechanical changes there. But again, is that permanent? No. Yeah, the thing about like when we look at like the body is that it's pretty adaptable to things. It responds to different loads. You just have to figure out which way to progress things. Hard to say. Um, you know, sometimes temporary orthotics are helpful for some sort of pain, but obviously, if it's causing pain in a bunch of different places, that's a harder conversation, right? Because do you want to treat one thing, but then set yourself up for multiple other things? That might not be a good trade-off. Um, and so, yeah, that's where you're just looking at going back to whatever healthcare provider and trying to figure out is this is this what you is this the path that you should be going? Um, I don't know if there's necessarily better orthotics per se. When looking at orthotics in general, regular orthotics versus custom orthotics, there doesn't seem to be much of a difference between the two. There might be some that you feel better with, but I don't know if that's specifically because they're custom made versus it's just a different fabric or different structure or whatever it is. So I don't necessarily know if there's a better orthotic per se. Obviously, orthotics do wear down over time, so that's obviously part of it as well. Of if you have an orthotic for over a year versus a month, there's probably some difference there in terms of the actual structure of the orthotic. Same thing with shoes. A new shoe will feel different than a shoe that you've been running in for 2, 3 years. So welcome everyone. Thanks for all 10 of you guys for being in here right now. Um, if you guys have questions, feel free to leave them in the comments here. This actually might be my longest live. We're almost at an hour here. This is the deep end. I think my first one was maybe only 30 minutes or so. So thanks again everybody for joining. Um, yeah, this is I think this is my third live that I've done recently. Um, and so yeah, but yeah, uh, I don't know. I remember when I first started clinical practice, I used to like think that I would use orthotics a lot more. Uh, I had a mold kit and all that kind of stuff where you'd step in, it would mold to your foot, and then they would build a orthotic off of that. Hello, welcome. Um, and I honestly really didn't use them as much. I just didn't find as much value, especially when looking at the price of the orthotic versus the outcome. It just didn't quite seem all that useful. Both from like myself of having orthotics, I didn't really notice that big of a difference, and then I kind of felt that it was a pain of if I was wearing a different shoe, putting in a different shoe, and remembering all that, and yeah, I don't know. I don't know. And then do you get multiple orthotics then? Because do you want one that you're running in and getting sweaty versus one that you just using every day? I I I don't know. So yeah, in general, I haven't used orthotics personally or even recommended them all that frequently. I don't know what the trend has been overall. I think some people definitely still recommend orthotics, but I think potentially it was bigger, I don't know, 10, 20 years ago. And now that our understanding of a lot of injuries has changed, that they're not quite as needed or not as frequently needed as previously thought. Obviously, there's still some cases where it's helpful, but not quite as much. All right. Any final questions as we kind of wrap up? Um, let's see here. Um, future stuff here. Um, we'll probably do another couple lives here. So far, we have done a general Q&A, which was the first one. We did proximal hamstring tendon last time, and then this one was obviously focused on the Achilles tendon. I think next time we'll probably do patellar tendon pain, which will be the next one. I typically, if this is your first time being here, I generally do these on Sunday mornings, or at least Sunday mornings here. I didn't actually schedule this one. It was kind of a surprise one, so apologies if you're looking for the notification, but typically I do them on Sunday mornings. If you like them, feel free to like the post, comment on future topics that you guys want to see, or just future videos that you guys want to see, obviously, as well. And yeah, hope everybody has a good weekend. And I know is it daylight savings when it gets pushed an hour forward? Whatever. Um, yeah, anyways, thanks everybody for joining, and we'll see you guys next time. See ya. Have a good weekend.